So without further ado, research to practice, the current and future landscape of locally advanced pancreatic cancer with Dr. Ashwin Somasundaram. Dr. Somasundaram, welcome. It's really nice to have you here.
Oh, thanks for having me.
Absolutely. So let's go ahead and we'll flash up some information about you, but we tend to talk in this way of introducing our guests in terms of your background. So MD is GI medical, as a GI medical oncologist in the Division of Oncology at the UNC School of Medicine. Let me know if I'm getting these right.
No, absolutely.
Okay. A focus on upper GI cancers and a research focus on tumor immunology and clinical research. Received a degree from the University of Texas Southwestern and did your residency and fellowship at the University of Pittsburgh, and takes care of patients with GI cancers, including gastroesophageal, help me out with that.
Hepatopancreatobiliary.
Thank you. Intestinal and colorectal cancers, and has particular interest in translation tumor immunology and early phase clinical trial development, especially in pancreatic cancer. We always do a kind of a softball question at the beginning. So pancreatic cancer affects your pancreas, a gland in your abdomen that aids in digestion. Symptoms include nausea, bloating, fatigue, jaundice, and lack of appetite. So we'll give our audience a few moments to answer, and then we'll see how they did. All right, and what was the answer on that?
Yes.
Yes, good.
True.
I was kind of thinking it might have been. so I'm guessing that folks did well, and we're off to a good start. So the current and future landscape of locally advanced pancreatic cancer. I'll turn this over to you.
Thanks again, like I said, for having me. It's a pleasure to be here. No disclosures. So we're going to talk about pancreatic cancer specifically. And so one of the things that comes up is, why is this important? Well, this is a pretty handy slide that a lot of us use in our presentations. And it's looking at 5-year cancer survival over the last 50 years and exactly where we've come. And you can see that the 5-year survival for a lot of these cancers has been pretty low, but we've made a significant amount of progress over the last 50 years. And a lot of that is thanks to advances in different therapy, targeted therapy, immunotherapy. But one of the things that we in GI medical oncology would like to point out is most of the cancers that we work on are at the bottom of this graph. And if you look at the very bottom, you can see pancreatic cancer, which not only has the worst 5-year cancer survival, but it's also had the least amount of progress over the last 50 years. So that means that over 50 years, despite so many advances happening for other cancers, and by the way, this is still older data. This has gone even further in the last 12, if we're including data from 2025. But that has been only minimally increased for pancreatic cancer. And so that is why this is so important to me and why I think this is such an important talk. When we talk about pancreatic cancer, you can think of it in terms of, can we cure this or can we not? And so in terms of cure, we're specifically talking about surgery. And so how do we get our patients to surgery? Well, the actual percentage can vary, but it's a very low percentage, anywhere from 10% that actually can be resectable depending on the studies that you look at. And a lot of patients come in already with stage 4 or metastatic disease where disease has already spread too far for surgery to be an option. And so one of the things we look at are patients that are right at the borderline when it hasn't spread too far, but it's large enough that surgery may not be an option. One of the things to point out is that pancreatic cancer is so aggressive is that the treatment and how we view them has a lot of overlap across all of these, but we'll focus specifically on the patients that maybe we can get to surgery, but still looking within the broader context of pancreatic cancer as a whole. So again, if curing means cutting, who can we resect? This is a very busy slide, and I want to emphasize that the point of the talk is not to go through all of this in great detail, but to show that there's a spectrum, and it can vary from institution to institution, provider to provider, but this is a general outline of how we think of things. And so at the very top, if there's no distant Mets and there's no involvement of vasculature or arteries or veins, and you're not having, significant attachment to other areas, then you can still talk about surgical resection, which means getting the patient to a cure. And then certainly at the bottom, if we're talking about disease that has spread very far or has spread to areas much further than where it started, or involving blood vessels like veins and arteries and encasing them, making it very difficult to remove the tumor, then it becomes clear that that is not going to be a good way to get the patient to surgery. And then there's a whole lot of criteria in the middle. Again, when we try to define it, we use specific terms and specific measurements. And so we go through, if you're looking at the head of the pancreas, which is the area that's connected to the intestines as well as the biliary tract. If the tumor that's there has more than 180 degrees involvement with one of the major arteries, then that's going to be considered locally advanced, possibly unresectable. And then same as we keep going down and we feel like we're getting to vessels like the superior mesenteric vein or the portal vein, if we can't reconstruct them, or we feel like it's too dangerous to be able to do a full resection, then this is also going to lead to a discussion with the patient that they might not be a surgical candidate for this disease, which means that cure would be off the table. And in terms of if the tumor is in the body, or especially the tail, this shifts a little bit, just given the location. Certainly if it's in the tail and if it's involving the spleen, we can still talk about surgery. But again, if we're talking about involvement of blood vessels, especially arteries, then it's going to be more and more difficult to talk about surgery. So there's technically no internationally recognized standard approach to management. And a lot of this is because of the limitations of the clinical data that we have. We need lots of trials with lots of patients to reach this sort of consensus. There are ongoing concerns about incomplete resections and having micrometastatic disease. And so that is going to be an ongoing concern across different institutions and different providers. So the questions are, what are some of the approaches to possibly downstage these tumors, where if we're borderline or if we feel like we can treat and actually get them to a place where they can have their tumors resected. So to answer that, we actually look to the advanced setting. So there's a lot of overlap between locally advanced disease that hasn't spread to other organs versus disease that has. A lot of this has to do with both the aggressive and insidious nature of pancreatic cancer, but survival is poor in both circumstances. And so when we talk about therapy, it makes sense to look at what we do for our patients that have very advanced distant disease. And so I would take a historic approach. These data aren't meant to give you what we currently do or what's updated, but rather to give you an idea of where we've been and what we've tried. So again, going back to that original slide, if we've been treating this for 50 years and we've made very little progress, what exactly have we done in the last 50 years? So 5-fluorouracil is a standard chemotherapeutic agent that we use in many cancers, especially in GI cancer. And that became the standard treatment for advanced pancreatic cancer in 1974. And that was a major breakthrough. And again, that's 50 years ago, but for us, that has still been the backbone and the mainstay of a lot of our treatment. It took over 20 years before another agent was really evaluated properly and found to have benefit, and that would be gemcitabine, where there was a minimal but still present survival benefit in the landmark study looking at gemcitabine over 5-fluorouracil. And then another 10 years passed before a combination was evaluated where gemcitabine plus a targeted therapy agent, a small molecule tyrosine kinase inhibitor that targets EGFR or epidermal growth factor receptor, was combined with gemcitabine, and that showed also some benefit in terms of survival and efficacy. And then finally, what we consider sort of the mainstay and standard treatment that we've used for now almost 15 years is the regimen known as FOLFIRINOX, which utilizes 5-fluorouracil like we had in the beginning, but also drugs such as oxaliplatin and irinotecan, along with leucovorin. And this has demonstrated a significant amount of survival benefit, and a lot of our trials are compared or evaluated against this standard of care backbone. And finally, there's the study from Dan Van Hoff looked at gemcitabine and nab-paclitaxel, which also showed significant survival benefit compared to gemcitabine alone. Also demonstrated good tolerability, and certainly is something that we consider in patients that have slightly worse performance status, or if we're worried about age or comorbidities or tolerability, compared to a more aggressive regimen like FOLFIRINOX. But if that's where we've landed after 50 years, does that mean that we haven't really tried anything else? And so if you go down a rabbit hole, you can see all of the agents that we use across all of their cancers have indeed been evaluated in pancreatic cancer. It's very low-hanging fruit to try to get benefit because patients with pancreatic cancer do so poorly. So many different agents and classes of agents have been evaluated in pancreatic cancer. And while I've shown it with a more broad overview, when you actually go through the studies, you can see exactly how many have been evaluated over the last 50 years. And it still brings us back to the regimens that we discussed previously, which is FOLFIRINOX, as well as gemcitabine nab-paclitaxel. Now, when we talk about those landmark studies, in a lot of other studies involving cancer, as well as just other medical studies, these curves may not seem as exciting. But I will say, in pancreatic cancer, because there has been so little benefit, even a separation of a curve that's relatively small is significant for us and our patients. And so when we look at the landmark study comparing FOLFIRINOX and the approval of FOLFIRINOX as standard of care compared to gemcitabine, it may not seem as impressive on the actual curves, but the hazard ratios do suggest that there is indeed a notable survival benefit. And when we treat our patients, we clinically see this compared to the folks that can't tolerate gemcitabine as well, or even those that can but choose a single agent over FOLFIRINOX. And so we definitely do see this benefit. Similarly, when we look at Dan Van Hoff's study looking at gem-nab-paclitaxel compared to gemcitabine, we also see a significant benefit in survival. More recently, we had the NAPOLI-3 study, which actually compared NALIRIFOX, which is liposomal irinotecan plus 5-fluorouracil and oxaliplatin, compared to gemcitabine nab-paclitaxel. There haven't been too many studies that have directly compared our two mainstay regimens. People have long hypothesized that FOLFIRINOX, being more aggressive, may have more benefit. Now, this isn't really comparing FOLFIRINOX to gemcitabine nab-paclitaxel, but there was a survival benefit that was found. And so because of that, NALIRIFOX is considered a FDA-approved regimen with suggested benefit over gemcitabine nab-paclitaxel and is considered by some to be a very reasonable regimen. However, how different is it from FOLFIRINOX still remains unclear. A lot of the things that are brought up is the dosing for FOLFIRINOX can sometimes be lowered for tolerability, and a lot of that didn't happen in this NAPOLI-3 study. But nevertheless, we do see that both regimens are reasonable, and NALIRIFOX might have a slight edge. Now, despite all of the things that I've shared, we still have not made a lot of success over the last 50 years. We've made some steps forward, but most patients still don't respond or have durable responses. And so the main question that we as oncologists are going to have is, what's driving this lack of response. And perhaps not all pancreatic cancer is the same, especially when we're looking at locally advanced pancreatic cancer. So using these regimens to try to downstage patients and get them from a place where surgery and cure is not an option, and then trying to get them to surgery. So what else do we know about pancreatic cancer? Well, the mutations that are known to be driving pancreatic cancer are largely around KRAS. 95% of patients with pancreatic cancer have a KRAS mutation, which I'll talk about in a bit, but recently, thankfully, we are starting to have agents to target these mutations. P53 inactivation has long been studied across many cancers, as well as P16 inactivation, and there are other parts of these pathways that oncologists and scientists have been trying to target for a long time, though it's been quite difficult. Besides other inactivation mechanisms, BRCA2 is well established because of its association with homologous recombination deficiency. So other genetic syndromes or mutations that you are born with, and germline mutations, can factor in. And certainly that's something to think about, especially when we're looking at, for example, patients that have germline BRCA-mutated pancreatic cancer. So this is also a New England Journal paper looking at patients that were born with a BRCA mutation, a loss of BRCA, either BRCA1 or BRCA2, and looking at patients that developed pancreatic cancer when they were in this setting. It's been evaluated in breast cancer already that the use of drugs such as PARP inhibitors, and in this case olaparib, might have benefit. And so the investigators of this study evaluated what would happen if they gave maintenance olaparib in place of chemotherapy or in place of placebo after chemotherapy, and to see if there was a survival benefit. And indeed there is. Now, there are some issues with this study with regards to how it really compares against what we do clinically as standard of care. But nevertheless, there is some signal that giving a PARP inhibitor to someone or a patient that has a BRCA mutation is not an unreasonable thing to consider. So how common is homologous recombination deficiency in pancreatic cancer? So a meta-analysis suggested that across 60 studies, over 20,000 patients, that it can be found in anywhere between 14 to 16% of patients with pancreatic cancer if you include a broad number of mutations. And in these cases, we specifically look at pushing regimens or regimens that have platinum-containing drugs, as there has been data to suggest that platinum-containing chemotherapy might be more beneficial and have more of an effect in patients that have homologous recombination deficiency. And similarly, looking at the use of PARP inhibitors is also something that has been considered and is reasonable to do in these patients. Now, how similar are these data in a neoadjuvant approach? So a lot of this has been in the advanced setting or in patients that maybe we could try to get to resection. If we're looking at patients that we think that we can already get to resection, FOLFIRINOX is largely considered the initial treatment for localized pancreatic cancer. And there have been many studies looking at this, but a retrospective analysis looking at around 1,800 patients that got anywhere between 4 to 8 cycles of neoadjuvant FOLFIRINOX, so FOLFIRINOX before surgery. The resection rates were around 17% for what was considered unresectable, and then 53% for patients that were considered borderline resectable. And in this retrospective analysis, overall survival was estimated to be around 18.7 months for unresectable and 23 months for borderline, which compared to the patients that are purely unresectable and then go on palliative chemo, or patients that have metastatic disease, this is certainly something that would be considered above the median for those patients. And it's hard to compare because they're not included in this study or in this retrospective analysis, but it's still food for thought in terms of considering FOLFIRINOX as a very strong and viable agent and regimen for patients that you're trying to get to surgery. So it's certainly reasonable to consider it in the patients that you're trying to convert. Now, when you bring up looking at FOLFIRINOX versus gem/nab-paclitaxel, again, bringing up something similar to what we discussed with the NAPOLI-3 study, there's an MD Anderson series looking at patients that got gemcitabine/nab-paclitaxel, and there were less responses compared to the patients that got FOLFIRINOX, and the overall survival, the hazard ratio, was actually similar. Again, possibly favoring FOLFIRINOX, but certainly not unreasonable. The reason I point this out is because this question comes up a lot in the community of, is it okay to consider gem/nab-paclitaxel in these patients that you're trying to downstage, or when you're trying to get them to surgery, or if you're considering it in the advanced setting. And again, we don't have a clear-cut answer because a lot of these are retrospectives and case series. There are some other studies coming out of East Asia that suggest that there may be some benefit or lack of benefit, and we're having more data come out in a prospective setting. But it's certainly not an unreasonable thing to consider, especially if you're worried if a patient can't tolerate FOLFIRINOX. I don't think it would be a disservice to the patient to consider gemcitabine/nab-paclitaxel in those cases. Another question is, what about the role of chemotherapy plus radiation? And so there's the PRIO-PANCS trial, which is a phase 3 trial across many centers, across 16 centers, and they combined chemoradiation plus gemcitabine and surgery, followed by further chemo after surgery, versus just surgery and then giving them chemo afterwards. There was not a significant overall survival benefit, but certainly the approach that included chemotherapy before as well as with radiation did have an increased chance of a complete resection and increased disease-free survival. Whether or not there was an issue with this study that there was no overall survival benefit, meaning that patients between the arms didn't have a significant improvement in survival, there can be possible other explanations for this, but the fact that there was some benefit still lends some support to the idea of doing chemotherapy plus radiation before surgery for these patients. This is very controversial and is institution dependent because there wasn't an overall survival benefit. So certainly depending on which institution that you go to and are being evaluated for pancreatic cancer, this can vary in terms of whether or not radiation is included or not. We have many trials, including ones at our institution, actively answering this and looking at other combinations with radiation. And so, are there similar approaches looking at other regimens? Some other regimens considered are gemcitabine oxaliplatin, gemcitabine capecitabine, which is a oral version of 5-fluorouracil, or 5-fluorouracil combined with radiation, and then the use of S1, which is a class of agents used primarily in East Asia. And ultimately, our approach has been, and including some of our sister institutions we've discussed this with, has been utilizing 6 months of perioperative FOLFIRINOX with an option to switch if there's been a progression or worsening findings at 3 to 4 months. So that with that, I'm happy to do some polling questions before we continue. Any thoughts on, should I just read the question, you think?
Yeah, let's go ahead and read the question, and then because this is being pre-recorded, we'll then go to where your answers are coming in live the day of, and then go back and hear the correct answer, or the best, what is the best option of those offered.
Sounds good. So the question is, a pancreatic head adenocarcinoma encases the celiac artery. So what stage would you consider would be the best description of this? How long do you think I should wait?
Oh, well, we'll go ahead and just let them know resectable, borderline resectable, unresectable, or metastatic, and then we don't really need to wait because we'll cut this part out and go to the live tomorrow.
Sounds good. Well, I think a reasonable approach to this would be that without any other additional information, calling this unresectable is a reasonable option, and I think that would be a reasonable response. Certainly, if I had included information about distant disease, you could consider this to be metastatic. And so the next question, very similar, a pancreatic head adenocarcinoma slightly abuts the superior mesenteric vein. What stage is it? What's the best descriptor for this? The options are resectable, borderline resectable, unresectable, or metastatic. Now, without any additional information, this could seem like a little bit of a trick question, but I would say that probably the best descriptor, even though it's a bit tricky to be able to settle on one thing, but the fact that it slightly abuts the SMV, I think borderline resectable is a reasonable response here. What is the first-line therapy for advanced pancreatic adenocarcinoma? The options are FOLFIRINOX, NALIRIFOX, gemcitabine nab-paclitaxel, or all of the above. Now, as we discussed, perhaps some regimens are considered better than others. Perhaps that benefit is minimal. Perhaps some are considered standard at most institutions. But I think a reasonable answer for this is that because it's so patient-dependent and because you need to take a lot of factors into consideration, I think all of the above is a reasonable response here. So with that, to continue on with our talk today, what can we consider for the future? So if that's the current landscape and where we are currently, what does the future look like? And where are we at right now in making steps forward? And so again, looking back and talking about the mutations that are driving pancreatic cancer, we have to ask which of these can be targeted. We talked a little bit about BRCA2 as well as just homologous recombination deficiency. But if we're talking about a lower percentage where it makes up about 14 to 16%, certainly if we could target KRAS, that seems like it would be very low-hanging fruit. So the role of KRAS G12C inhibition in pancreatic cancer has demonstrated significant responses. So in many tumors, but specifically in lung cancer, we've had a lot of success in targeting KRAS G12C, that specific allele, that specific mutation. And unfortunately, in GI cancers, pancreatic cancer and colorectal cancer, the percent of patients that have a G12C specific mutation is very low, sometimes estimated between 1 to 2%. And so very few patients are going to derive benefit. But if you are able to identify a patient with a G12C mutation, then that certainly does open up the possibility of just an oral tyrosine kinase inhibitor that has much less side effects than traditional, more aggressive regimens of chemotherapy and still has significant responses. And so we show here that there is findings of 6.9 months of median overall survival on patients that had received KRAS G12C. And so then, other things we would look at is looking at, well, what about P16 inactivation if that's also greater than 95% frequency? And so more data is coming out, more trials are occurring, including at our institution, looking at patients that have MTAP deletions in their tumor, and this is related to the P16 pathway, but specifically with MTAP deletion, we can see it anywhere between 20 to 40% of our patients with pancreatic cancer, and recently more and more agents and drugs are coming out targeting PRMT5, which promotes synthetic lethality, encouraging tumor death. And so these are still in the phases of clinical trials, still in phase 2 and now moving towards phase 3. but we're very excited about being able to move forward with these targeted therapies. These data are just from the last 9 months, and they're being updated pretty much every month. And this is looking at pan-RAS inhibitors, or looking at specific KRAS inhibitors. In this case, it's a pan-RAS inhibitor in patients that have already received therapy for pancreatic cancer. And again, patients that have already had their cancer get worse after their initial therapy have a very poor prognosis. Other regimens of chemotherapy have some benefit, but certainly the findings from this agent from Revolution Medicine has been very impressive. And so we have more data coming out as we speak that we will share as soon as we're allowed to and it's made public. But it's become very promising to the point where we are having our patients go to great lengths and great distances to be able to get on one of these agents if there is a slot available anywhere in the country. And so the area of targeted therapy for pancreatic cancer, especially within KRAS and involving KRAS treatment and combinations, is moving very quickly. And so are there other types of pancreatic cancer, and what else are we looking at? When we look at breast cancer, over the last 50 years, evaluating breast cancer and beyond, they have been able to categorize their cancer into many, many different subtypes. Pancreatic cancer is largely looked at as one subtype, but we have about 15 years of data suggesting that molecularly and clinically we have at least 2 very different subtypes. And so this is established with many of the leading pancreatic cancer research groups across the world, especially across the United States. And a lot of it has been supported also by work here at the University of North Carolina, looking at 2 different subtypes. One is basal subtype, which makes up about 15 to 25% of patients with advanced disease, including locally advanced disease, that do not respond well to FOLFIRINOX chemotherapy, do not respond well to therapy, period, but especially not to FOLFIRINOX chemotherapy. And these are updated data from Dr. Jennifer Knox and the group of the PASO-1 study, demonstrating that if you have a basal subtype cancer, you have a very poor prognosis. And the more traditional classical subtype is the one that is actually more responsive to FOLFIRINOX chemotherapy. However, this is something that is not routinely tested for our patients in standard of care, and that's because we don't have a prospective clinical trial looking at these subtypes and actually determining what we should be picking for these patients that might be best, even though they seem very different, again, genotypically as well as clinically. One of the tests was actually developed here at UNC. There are many great tests across the country, but one that has sensitivity and specificity anywhere from 95 to 99%, depending on the cohort that was evaluated, is Purist. And we've actually validated it using a nanostring platform to be able to get a turnaround time of 5 days. This has been evaluated with Dr. Susan Tsai, previously at MCW, but also at Honor Health and at the Ohio State University, looking at it in a neoadjuvant setting. And so they've been able to utilize this assay to actually finally look at different subtypes. Recently, the genomic testing company Tempus, who many institutions utilize, including us at UNC, has also been utilizing their version of Purist subtyping for pancreatic cancer. And so this is certainly what the future looks like, what we believe the future will look like for pancreatic cancer, now that so many institutions and companies are starting to adopt this methodology of looking at and prospectively evaluating and making treatment decisions based on different subtypes. But just because we know that there are 2 subtypes and basal subtype does worse, is there something we should be looking at perhaps that could improve survival or make it better? One of the things that came out from this paper with Gary Johnson and Jen Genier at our institution was looking at kinases that drive basal subtype cancer versus classical. And they found, again, EGFR had a very strong signal for driving basal subtype. And when they looked at prior studies, some out of Germany, that combined gemcitabine plus EGFR inhibition, there didn't seem to be any overall survival benefit between those patients. However, our group here at UNC evaluated them by subtype and found that if they had selected only for basal-like patients, then there would indeed have been a survival benefit in patients that got EGFR blockade. Now, this is just a retrospective study, but other studies have also looked at what happens if you give a KRAS inhibitor to patients that are basal subtype, and they've also had some data suggest that those would be the patients that would derive the most benefit, and this is out of Andy Aguirre's group at Dana-Farber and Tomas Tamella's group at Memorial Sloan Kettering. And so we have a study here at the University of North Carolina where patients that have yet to be treated with advanced, so including locally advanced metastatic disease, that undergo subtyping with our purest assay, and those that are classical subtype will go on to get standard of care, and we'll evaluate them independently for platinum-based therapy. And the patients that are basal subtype will get gemcitabine, nab-paclitaxel combined with EGFR inhibition with erlotinib. And so we've been actively accruing to this study, and we have some very interesting but early data so far. And we've had a lot of interest across the country, with many sites wanting to join just because of their interest in looking at subtyping and further establishing this as practice and being able to use it as a platform study to look at other combinations that may benefit these subtypes of cancer. And again, I point out the importance of this because of how different it has been relative to other cancers, such as breast cancer, when we're able to look very granularly at breast cancer and see how many different types there are and how differently we should be viewing each of them and treating them. And something we find sorely lacking in pancreatic cancer, and we're hoping that this will be a big step forward in making that happen. And these days, there would be no talk that'd be complete if we didn't talk a little bit about immunotherapy, given the absolute revolutionary strides it has made in cancer as a whole. Unfortunately, that has been sorely lacking in pancreatic cancer. So when we talk about immunotherapy, a lot of it has been around checkpoint signals or checkpoint blockade involving T-cell, anti-tumor T-cell-based immunity. But in such as, blockade of CTLA-4, PD-1, that has not been as beneficial in advanced pancreatic cancer outside of the very few patients that have microsatellite instability. Instead, looking at other ways of targeting pancreatic cancer using immunotherapeutics, a lot of it's been limited by the dense stroma that has been excluding immune cells and T cells from actually getting into the tumor as well as sites of metastatic disease. An example is a phase 1 study looking at nivolumab, anti-PD-1 therapy, plus gemcitabine nab-paclitaxel. And as you can see, there was not a significant benefit in phase 1 study, at least. And then talking again about a subset of microsatellite instability high GI cancers, 1 to 2%, those that were pancreatic did have some benefit, but that's well established across all tumor types because of the high degree of mutation burden. So again, that is something that can be considered as a reasonable approach for immunotherapy, but it makes up a very small percentage of patients. However, one of the more interesting things that came out in the last 1 to 2 years was the role of a personalized mRNA vaccine therapy targeting key neoantigens. And so this came out of Memorial Sloan Kettering with Vinod Balachandran's work, looking at tumor resection and the development of a personalized vaccine based on each individual patient's tumor. And they found that if a patient had an immune response if they measured and they were able to find an immune response, those patients had a significantly improved recurrence-free survival. So the chances of their tumor coming back was very low compared to those that did not develop an immune response to their personalized tumor vaccine. This is a very exciting study, and these updated data from that study suggesting that there might still be a benefit possibly in the surgically resectable setting. However, for the purposes of this talk, the goal would be trying to get that to a place where perhaps it would have a benefit and the patient could actually get downstaged for surgery. And that still seems to be an area that we are lacking. Another area has been looking at B7H3, both in terms of antibody drug conjugates, because there's been positive data targeting this as an immunotherapeutic antigen. And so looking at B7H3, we have a study at our institution combining that with a CAR T approach, so having re-engineered patient T cells targeting that tumor antigen. So that's being evaluated in a phase 1 setting, still with some early and very interesting data at our institution. And so all of these show within the microcosm of our institution what we're doing to make steps forward and bring the future of pancreatic cancer forward. Certainly it represents what a lot of other institutions across the country are doing with similar approaches. So I can say it's a very interesting, exciting, and hopeful time for our patients. And so we're hoping to have a lot more interesting data in the next few years. That I'd like to acknowledge patients and their families, everyone at Lineberger, and everyone that has provided data and information to make this talk possible. I'm happy to take any questions and have a discussion.
Great. So I've got a few for you, and then we'll have more when we air this. So worst 5-year survival, worst progress. From what I've read, transplant is not usually a viable option. What is it that makes pancreatic cancer so challenging? All cancer is challenging, but can you tell our audience what are some of the factors that specific to this cancer type?
So that is a very multifaceted answer for that question. So I would say that one, it is very immunologically cold. It is very dense. There is a lot of stroma, which makes it very difficult for immune cells to get in and do their job.
Gotcha.
I would say in the last 10 years, we've really learned a lesson in terms of cancer research and oncology that the immune system does a lot of heavy lifting for making sure our patients get a long-term benefit from cancer therapy. Even those that go on chemotherapy, there's still an immunologic response. So you still need to have your immune system intact and active and able to see tumor antigens. So the fact that these tumors are so cold and don't let in any immune cells or antigen-presenting cells, or make sure that if they do come in, it is very harsh for the immune system to do its job. We think that that is one possibility.
Okay.
Another is just its insidious nature. And when I say that, I mean that by nature of how it is presenting and how it mutates over time and the progression of pancreatic cancer, it seems to be able to have micrometastatic disease, so areas that it has spread to early on, while it is still very small. And so we think of tumors as, those that are kind of getting close to 2 centimeters as still relatively small. But even at small sizes, even when it's still hidden and it's hard to find, it is still seeding out micrometastatic disease. Other tumors can do this too, but we're seeing that pancreatic cancer, we think that would explain why, even for the patients that we get to resection and undergo 6 months of chemotherapy, 2 out of 3 of them will still have their cancers come back, because we have such a hard time eliminating any of those stray cells of micrometastatic disease, and the fact that they have already been so far gone and mutated and spread while we still thought that we could get them to surgery.
Gotcha. Thank you so much. We've seen a lot of advances in screening with certain types of cancer. Have there been any advances, or are there any on the horizon with pancreatic cancer?
That's a great question. So one of the most common areas for screening in pancreatic cancer has to do with certain cystic benign lesions called IPMNs. And so when you see a cystic lesion that's consistent with an IPMN, we have guidelines on how to screen for pancreatic cancer in those patients. And similarly, we screen for patients that have a family or genetic history for pancreatic cancer, really any of those germline inherited BRCA1, BRCA2 homologous recombination deficiencies. Still, it is not set a standard of care for screening for all patients, all people, with the use of, say, a CAT scan or an MRI or an endoscopy. We haven't gotten to the point where we have data to say that that would be of enough benefit, or if there's a good way to identify which patients need to be screened in such an invasive manner. So that is still an unknown, but there are some key populations we can still think about doing that for.
Good. Let me see if I understood you correctly. When you were talking about the two major subtypes, the basal-like and the classical, you said you're not typically testing patients at this point. Is that, and I wanted to make sure I understood, is that primarily because it wouldn't impact the treatment at this stage, and that we hope in the future that it will?
You know, I'm very biased, so I will tell you, I love that question, because the obvious thought is, if we've had 15 years of data suggesting that this is the case, and we've had all of these retrospective studies showing how distinct these tumors are, and that it does impact prognosis, even if it might not sway you one way or another with regards to therapy, there's still data suggesting that they should be treated differently.
Right.
Why are we not adopting this as standard of care? And so it has been I want to say one of my many missions in the last 1 to 2 years to actually make that a reality. The reason why we don't is because we don't have enough prospective data, or we've done a formal prospective clinical trial saying that we do see a formal difference when we do test, and it does make a difference, and that picking a regimen based on this testing does make a difference. But most academic institutions, most of the thought leaders in their practice, they will have either a trial or some way to evaluate this. Most of the pancreatic cancer trials, a lot of their exploratory research will include a line about retrospectively looking. But as part of standard clinical practice, it seems that we're not quite there yet that we can incorporate that into our decision making, and we're hoping that some of these studies that we have here at UNC and that our collaborators have at other institutions will make that a reality in the next few years.
Good. Well, we will look forward to having you back at some future date, and hopefully you can tell us about that research and the impact thereof. If you can pass the keyboard back to me, I'm
Here
going
you
to go ahead and just go through. Whoops, I'm sorry, Patrick. I beg your pardon. I accidentally thumbed the escape key on the keyboard. If you can put that back up, thank you. So I do want to say thank you. I want to say thank you to the state of North Carolina for the University Cancer Research Fund, and that's where we receive our funding for the UNC Lineberger Cancer Network. We want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank the team, Venny Obore, John Powell, Oliver Marth, Andrew Dodgson, Patrick Muscarella, Kim Riddick, for all of their hard work on this and every one of our lectures. It really takes a village, takes a team to make this happen, and these folks are amazing.